Okay, let's talk about the embryology pathology, right? Congenital heart diseases. So in congenital heart diseases, what do we have? We have right to left shunts. Right to left shunts. And these right to left shunts are going to give us early cyanosis, which is blue babies, often diagnosed prenatally or become evident immediately after birth. Okay, so these right to left shunt diseases, which are the 5Ts, they will be seen right after birth, immediately right after birth. So baby is born, the baby is blue. You're gonna think about 5Ts. You're gonna think about right to left shunt, and it is immediately after birth. And it usually requires urgent surgical treatment and or maintenance of a PDA. Important. What are the 5Ts? The first one, we have the truncus arteriosus, the one vessel disease, transpositioning of great vessels, which is two vessel disease, tricuspid atresia, 3 means tri, tetralogy of Fallot means 4, tetra, fifth is TAPVR, is the total anomalous pulmonary venous return, and sixth, which is not here, is going to be your Abstein anomaly, which is at the bottom of the page. Abstein anomaly. So Abstein anomaly. Okay, so let's look at the first one. The first one we have is PTA, patent truncus arteriosus. What is patent truncus arteriosis? Well, the truncus arteriosus is not dividing. So let's just, so this was truncus arteriosus. Normally would divide into aorta and the pulmonary arteries, but now here what's happening is it's not even dividing. So you have truncus arteriosus, which is patent, and what's going to happen is you will have mixing of fluid. So aorta fluid is coming here, the blood, and from the veins the fluid is coming here. It's just mixing all together. Okay, this is, let's say, aorta, and this is, let's say, pulmonary. So truncus arteriosus fails to divide into the pulmonary trunk and the aorta due to failure of, why did it occur? Because of the failure of aorticopulmonary septum formation. So that AP, aorticopulmonary septum, did not even form, that caused the problem. Now the patients would have, most patients would have accompanying VSD as well on top of it. But that is all for the patent truncus arteriosus. Okay, now looking at the second, which is called transpositioning. It's a transposition of great vessels. So aorta leaves the right atrium anteriorly, and the pulmonary trunk leads posteriorly. Mnemonic is A for A, aorta anterior, and this is not normal. Normally it should have been aorta should be posterior, but here, because there is a transpositioning of the great vessels, so aorta leaves anteriorly. A for A, aorta A, anterior, and pulmonary trunk leads left ventricle posteriorly, leads to separation of systemic and pulmonary circulations, not compatible with life unless a shunt is present along the mixing of blood, VSD and ASD. So if you look at, let's just draw a picture here, which is also here, is that instead that from the right ventricle you have a pulmonary artery. This is normal, right? From left ventricle you will have aorta. This is normal. So instead of this, what's happening is from your right ventricle you're giving off aorta, and from your left ventricle you're giving off your pulmonary artery. We're looking at here, this is left ventricle giving off pulmonary artery. Here is the right ventricle, it is giving off aorta. So what's going to happen is aorta circulation all will come back here. You have two sort of different circulation which are not matching with each other, right? Pulmonary artery goes back into the left atrium, and they're not connected with each other, so it is incompatible with life. So you got to have a connection. What connection can you have? You could have a VSD, you could have a PDA, which is here, VSD, PDA, or patent foramen veil, for the life to be to live, right? Otherwise this is not a condition in which you can have a livable condition. So it is due to the failure of, now why did it happen? It is a failure of aorticopulmonary, again the same thing, aorticopulmonary septum to spiral. Okay, Narrow superior mediastinum causes agon sting appearance on chest X-ray. Agon sting appearance without surgical intervention, meaning you either make intervention and make a connection. Most infants would die within the few months of life. They would die within a few months of life. So going back, the problem here was aorticopulmonary septum formation. So AP septum didn't form. Here the problem is AP septum spirals. If it does not spiral, AP septum spiraling problem. So if it doesn't spiral, what does it do? They will ask you, and that is AP septum forms a linear instead of spiraling. Okay, that is important. Next thing is your tricuspid atresia. It is the absence. Again, the name says right there. Atresia, atretic. Who's atresia? Tricuspid. So tricuspid valve is atretic. It's absence, or it can cause hypoplastic right ventricle. Because if you just, look at any picture you have here. You have here you have this tricuspid valve, right? So if this is not formed or this is absent, you have just the pressure is equalized with the right atrium, so there is hypoplasia of the right ventricle because there's no separate department for it, right? So it's a hypoplastic right ventricle. It requires an ASD and a VSD for viability. Okay, so that the fluid can go from one side to the other side. Okay, because as soon as the right ventricle pushes, less blood goes in here and more blood goes back to the right atrium, right? Like up top. So you need ASDs and VSDs for the viability. Tricuspid atresia. The next thing is your tetralogy of Fallot, high yield. What is tetralogy of Fallot? It is anterior superior displacement of the infundibular septum, high yield. Infundibular septum. Infundibular septum. What is infundibular septum? Well, the infundibular septum is, we will talk about what infundibular septum is, but there is a deviation, there is a displacement of that infundibular septum. And what is that? It is the pulmonary infundibular stenosis, deviation causing that infundibular stenosis, right? And that, in other words, they will call this thing as right ventricular outflow tract obstruction, RVOT obstruction. So pulmonary infundibular stenosis, RVOT obstruction, which is seen, let's just zoom in, which is seen right here, what you have in the pulmonary stenosis. Here is the RVOT obstruction. Pulmonary stenosis, it is also known as RVOT obstruction. It is also known as pulmonary infundibular stenosis. Okay, three things, but one of the same thing. And high yield, why this is high yield? Because degree, let's just say that here. So degree of right ventricular outflow tract obstruction is the major determinant of severity of the symptoms. It's a major determinant of the severity of the symptoms. So RVOT obstruction, pulmonary infundibular stenosis there. Second point is very high yield is mnemonic proof. So we are talking about proof. P for pulmonary infundibular stenosis, or for right ventricular hypertrophy. So if you look at the right ventricular, it went into hypertrophy. So right ventricular hypertrophy. Third thing is overriding aorta. Look at the aorta. Aorta is right here, but look, aorta is just overriding. It is not only, look, let's just zoom in. Aorta is just overriding. Look at aorta, okay? It is overriding. So you have overriding aorta. Right ventricular hypertrophy, pulmonary stenosis, overriding aorta. On top of that, the last one is going to be your VSD. Here's the VSD. So all of the four things which are proved, which are also seen here. PROVE, ROV. There is no E. Okay, PROV. Okay. Then you have this pulmonary stenosis, forces the right to left shunt. again, we did talk about pulmonary stenosis as a major thing here, which talks about the severities dependent upon how much stenosis you have, how much infundibulous stenosis, how much pulmonary, which is the same thing as calling it pulmonary stenosis, how much pulmonary stenosis do we have, and that pulmonary stenosis forces the right to left shunt, and that right to left shunt across the VSD causes right ventricular hypertrophy, and then you have this TET spells often caused by crying, fever, exercise due to exacerbation of right ventricular outflow tract obstruction. All of these things, crying, fever, exercise, they will lead to exacerbation of right ventricular outflow tract obstruction, which is pulmonary stenosis, and that is known as that will give you TET spells. And the one of the things that is not mentioned here, how you treat the TET spells. To treat the TET spells, the child, the very high yield is, they will say, okay, child gets into the squatting position. Child would squat. Okay, so basically squatting means when your knees are touching your chest and you're just sitting down. Okay, that's squatting. When the child goes into the squatting position, it leads to improves the patient's cyanosis. Improves that cyanosis. Right? And that improves cyanosis, and the patient is just going to do it again and again whenever whenever he gets into TET spell. For example, he's playing. Exercising means playing, right? The child is playing, and right after some time you see a child, he's just squatting, and he was blue first, but now he's all fine, and he again gets up and starts playing. This child has tetralogy of Fallot, in which case he had a TET spell, he went into squatting, improved the cyanosis, now back to playing, right? So that is what you have. What else you might see? Okay, you will also see, we said VSD, so you will see VSD murmur. What is a VSD murmur? Again, the VSD murmur we did it here in the cardiology. That's the harsh systolic ejection murmur. Harsh systolic ejection murmur, right? Yeah, you can call it pansystolic too as well. So yeah, harsh systolic, pansystolic ejection murmur at the left upper sternum border. Uh, yeah, for sure. So you have a VSD murmur can be seen, but on top of that, there's another murmur that you can also hear here. That is going to be your pulmonary stenosis murmur. Okay, uh, so because you have a VSD, now important thing is one more high yield point is because we said in the VSD that if you have a bigger VSD, it's not going to give you a prominent murmur. So in these tetralogy fellow patients, you will not see a prominent VSD murmur, but what you will see is the prominent pulmonary stenosis murmur. And that pulmonary stenosis murmur is going to give you a harsh systolic ejection murmur. Hard systolic ejection murmur at left upper sternum border due to RVOT obstruction, again due to pulmonary stenosis, and plus minus VSD murmur. But because it's too big, so not much of a VSD, but for sure pulmonary stenosis murmur. Okay, on top of that, what else you might have? Oh, very high yield. Okay, very high yield is the DiGeorge syndrome here. It is associated with 22q11 syndrome, which is called as DiGeorge syndrome. DiGeorge syndrome. And what else? You have, again, we talked about squatting, but let's see what squatting does. Squatting increases the SVR, which is systemic vascular resistance, which is same thing calling increase in TPR, which is total peripheral resistance. So when you squat, the vessels, they increase the resistance, so increasing in the TPR or SVR. That would decrease the right to left shunt. Why? Because now you have increased the pressure here. So let's just do it here. Because these vessels, let's say here, you have increased the pressure here. That pressure is going to go back and increase the pressure in the left heart. So now it's going to be hard for the right side to push the fluid into the left because you have a lot of pressure there. And that will improve the cyanosis. And what was cyanosis? The deoxygenated blood. The deoxygenated blood was going into the oxygenated blood, and that was causing cyanosis. But since we have increased the pressure here, there isn't the blood, the oxygenated blood isn't going into the left ventricle, so it will improve the cyanosis. And that is all. And also, high yield is the boot shaped heart. It's going to give you where they haven't mentioned it here. Where is okay? And boot shaped heart on the chest X-ray right there. So boot shaped heart on chest X-ray, tetralogy of fellow. Okay, moving on with the next one, which is called as total anomalous pulmonary venous return. Total anomalous TAPVR. It is the pulmonary vein drains into the right heart circulation. Pulmonary vein again, where it's supposed to go? Pulmonary vein is supposed to go into the left atrium, right? But it now drains into the right heart. So instead of going there, it goes into the right atrium. Let's say it comes and drains here, either in the directly in the superior vena cava. This is SVC. It drains into superior vena cava or coronary sinus, which drains into the right atrium, right? Associated with ASD. So your associate this thing is associated with ASD. Sometimes PDA can do allow for the right to left shunt to maintain cardiac output, because all the fluid is coming here. How is the fluid is going to go to the left atrium, left ventricle, and eventually to aorta? Not possible. So you need some shunts. So either the PDA that you have directly going into aorta, or you have this ASDs. But important thing is, as the name suggests, total anomalous pulmonary venous return, meaning the whole thing, total anomalous, whole thing is full of anomaly, in which the pulmonary venous return is bad. So where is bad? It's just going into the right atrium. Simple. Okay, moving on to the last one, which is called Epstein anomaly. Epstein anomaly is displacement of the tricuspid valve leaflet downward into the right atrium. Okay, so here you have. So you have a downward displacement of the, instead of being normal here, let's say, now it has displaced in the right ventricle. So when you have displaced this into the right ventricle, it will lead to atrializing the ventricle. So atrial muscle, it will just go down. It will atrialize this ventricle associated with tricuspid regurg. And plus, you will have a lot of regurg because this is just leaflet has been displaced. So when the ventricles contract, they will push the fluid back into the right atrium, and that is called regurg, tricuspid regurg. Accessory conduction pathway and right heart failure. Right heart failure. Why? Because how much this guy is going to work right ventricle. Eventually, it's just going to fail and leads to right-sided heart failure. Can be caused by lithium exposed in utero, high yield. Epstein anomaly. That's how most of the questions will come in, like lithium and lithium exposure in the utero, Epstein anomaly. Other thing is Wolff-Parkinson syndrome, right? WPW, Wolff-Parkinson-White syndrome. So lithium leads to Epstein anomaly. Lithium leads to Wolff-Parkinson-White syndrome. And important high yield point, atrialization of the right ventricle and displacement of the right ventricle leaflets if you have lithium exposed in the utero. So let's just recall this page and move on to the next page. This page is simple. What are we talking about? We are saying congenital heart diseases, right to left shunts. Right to left shunts are going to come with blue babies immediately after birth. So you got to do right away something. There are the 5 T's. 5 T's being, the first T is the truncus arteriosus, patent truncus arteriosus, that the truncus arteriosus did not divide into the pulmonary trunk and aorta. So there's a mixing of the blood between each other. Why did this happen? Because of aortopulmonary septum did not form. That's one thing. Transposition of great vessels, because of aortopulmonary septum, did not spiral. What did it do instead? It went to linear. What was the problem? Aorta is now living anteriorly, and the pulmonary will go posteriorly. Okay, and it is now one more high yield point which is not mentioned here. This guy is going to be associated with maternal diabetes. Okay, tricuspid atresia. Tricuspid has been atretic. You will have hypoplastic right ventricle. Tetralogy of Fallot, the mnemonic prove. Pulmonary infundibulous stenosis, which is also known as right ventricular outflow tract obstruction. You have right ventricular hypertrophy, which will give you boot-shaped heart, and you have overriding urina VSD. TET spells, squatting will fix the TET spell, mnemonic prove, associated with discharge syndrome. Total anomalous pulmonary venous return, the full pulmonary venous return are just coming back into the right heart circulation, meaning SVC or coronary sinus instead of going to the left atrium. Okay, and the last one, which is abstinent anomaly. Abstinent is the displacement of the tricuspid valve causing atrialization of the ventricle caused by lithium in utero. And that is all for right to left shunt in the congenital heart diseases. Now let's talk about left to right shunts. So left to right shunts, these patients are going to be acyanotic, high yield. Now we're going to compare contrast. Right to left shunt were cyanotic. These are acyanotic at presentation, and they will come after years after birth being cyanosis. So they will get the cyanosis, but years after birth. The other guys, they were right after birth. Blue babies right after birth. These guys, cyanosis after years. Frequency, the VSD is most frequent, then ASD, and then PDA. So the mnemonic they have is right to left shunt is early cyanosis, so RL cyanosis. Left to right shunt is later cyanosis, LR mnemonic cyanosis. Now let's talk about VSD. So in VSD, what do we have? So VSD is simply you have a defect here which causes left to right shunt. Why? Because pressure here is a lot and there's low pressure here. So fluid is just going to go easily towards the right side. So let's look at this. It is asymptomatic at birth. May manifest weeks later or remain asymptomatic throughout the life. Most smaller defects self-resolve. Larger defects, if left surgically untreated, cause increase in pulmonary blood flow and left ventricular overload. Again, if you have a large VSD, what's going to happen? Let me just draw it here. You have more fluid going into the right atrium. From right atrium is right ventricle. From right ventricle, a lot is going to go to pulmonary vein. That a lot pulmonary vein will go back into where? Left atrium. From left atrium, left ventricle. So what you ended up having? Left ventricular overload, right? Because you have increased the fluid that circulates and gets back to the left ventricle. So increase in pulmonary blood flow, increase in left ventricular outflow overload, which can progress to heart failure. I mean, you keep doing it every time. What's gonna happen is the heart gonna say, "Hey, come on, you aren't paying me enough, so I'm just gonna say bye-bye." It's gonna go to failure, right? So O2 saturation increases in the right ventricle and pulmonary artery. How is that? Simple again. If you look back here, you are talking about right ventricle, left ventricle. This is oxygenated blood. When you have a VSD, oxygenated blood goes here. Guess what's going to happen? Right ventricular O2 saturation increases. So there is an increase in a right ventricular O2. And even the pulmonary artery will have, because from fluid from here is going to go to pulmonary artery, it will have increase in O2. Simple, right? No rocket science about it. And now, as we were mentioning about that holosystolic murmur, so let's talk about that VSD. VSD will give you harsh holosystolic, or in other words, you can call it pansystolic murmur, pansystolic blowing murmur, or holosystolic blowing murmur at the left lower sternum border. Okay. And that is one of the things. Again, with larger VSDs, you will not get a lot of murmur sound, but with the smaller, you will hear the murmur. Okay, what is this associated with? it is going to be associated with fetal alcohol syndrome. Fetal alcohol syndrome. It is associated with fetal alcohol syndrome. And that is going to be all for this. Okay, now we have the next one called ASD. ASD, it's again, if you have ASD, it's simple thing. You have ASD right here, from right atrium to left atrium. It is defect in interatrial septum, right? Wide fixed splitting, high yield, wide fixed splitting of O2. And we did talk about how you would have S1 and S2, right? And we had S2 divided into A2P2. A2P2. So here you have a wide, let's say in an inspiration, what's going to happen is this thing is going to be wide, so P2 will close later. And fixed, meaning either you would have wide, which is most prominent, or you would have fixed, meaning with inspiration and with expiration, you would have just widened split. And that is again in physiology, and you can take a look at that. We did that already. So ostium secundum defect, most common. Ostium secundum was the second one which came down, right? So this is a problem in ostium secundum. Usually an isolated finding. Ostium primum defect is rare and usually occurs with the other cardiac anomalies. Symptom range from none to heart failure. Distinct from pitted foramen veil, which is due to failed fusion. PFO is failed fusion of the ostium secundum and ostium primum. Remember that in the normal embryology we did talk about this thing, and that was patent foramen veil. If they fuse together, it's called fossa ovalis, right? And they're saying now this one is specifically for the septum, atrial septum, the defect in the atrial septum. Here you can have an increase in O2 in the right atrium. Again, same thing. You will have from left atrium, which is oxygenated blood, goes into the right atrium through this, and there will be increase in O2 in the right atrium and the right ventricle and the pulmonary artery. So because the circulation goes this way, so you already know that, okay, it's going to increase in all the rest of things. May lead to paradoxical emboli, meaning what is paradoxical emboli, which is systemic venous embolus uses ASD to bypass the lungs and become systemic arterial emboli. It is associated with Down syndrome. What is a paradoxical emboli? Paradoxical emboli is, although we are saying right now that it is left to right shunt, right from left side to right side, but in cases when you have increase in right atrial pressure, for example, you're coughing, sneezing, squatting, Valsalva maneuver, you're increasing right atrial pressure. When you increase right atrial pressure at that time, it could the shunt becomes reversed, meaning from it becomes right to left shunt. And let's say you had emboli at that time, that emboli could just through the ASD could go into the left atrium. From left atrium goes to left ventricle, and from left ventricle goes into the cerebral perfusion and goes and causes stroke, or goes to GI, causes ischemia to the mesenteric vessels. Anything can happen, and this is called paradoxical emboli. Okay. High yield is association, which is Down syndrome, and fetal alcohol syndrome for top one. The next one we have the patent ductus arteriosus. Patent ductus arteriosus is in fetal period. Shunt is given right to left normal. So normally the patent ductus arteriosus in the fetal period is just giving right to left shunt. But in neonatal period, there is a decrease in pulmonary vascular resistance, leads to shunts become left to right, leads to progressive right ventricular hypertrophy, or progressive right ventricular hypertrophy and or left ventricular hypertrophy and heart failure. So again, what are we trying to say? In fetal period is all normal because we need that. right? And we did talk about it in the normal embryology, that we need the PDA, and that is in the fetal period. But as soon as, but as soon as uh, in the neonate, as soon as the baby is born, you have a decrease in pulmonary vascular resistance. Why do you have decrease in pulmonary vascular resistance? Because now the fluid is now there is no more fluid in the lungs. It is now air in the lung, because the baby is breathing now. With the air, you're just decreasing the resistance. When you decrease the pulmonary vascular resistance, the shunt becomes left to right. Excuse me. The shunt will become left to right. And what do we mean by left to right? That instead that from pulmonary vasculature, this PDA, pattern ductus arteriosus, sends the fluid out into the aorta. Now what's going to happen is that from aorta is just going back from PDA, pattern ductus arteriosus, to the pulmonary vessels. And that's what they mean by left to right shunt and reversal. And that would cause what? So this is, let's say, aorta. So PDA is here. So more fluid is going to come back to the pulmonary vessels. So when the more fluid is going to come back to the pulmonary vessels, what is going to happen is that they will a ventricle would have to push a lot harder to push the fluid back into the pulmonary vessels, right? Because there's already fluid coming from the aorta. So that is going to cause right ventricular hypertrophy. And when you push it down, and or left ventricular hypertrophy, meaning when you push it down, first of all, there is going to be decreased blood flow, right? When there is decreased blood flow, there's going to be increase in heart rate, vasoconstriction, everything is going to happen. And that fluid that you push in from here, and you get the fluid back from here, all of this right ventricular, pulmonary vasculature fluid will eventually go back to where? Left atrium. From left atrium again goes to the left ventricle. From left ventricle is going to try to push that fluid back into the aorta, and it's just fluid overload that will cause left ventricular heart failure, left ventricular hypertrophy and heart failure because of fluid overload. Okay, it is associated with very high yield as machine-like murmur. Patency is maintained by two things. One thing is PGE, prostaglandin E synthesis, and the low O2 tension. So patency, to keep it open, we need a PGE E1 and 2 and low O2 tension, low oxygen. So if it is uncorrected, PDA can eventually result in late cyanosis in the lower extremity, which is also known as differential cyanosis, high yield point. Differential cyanosis. What is differential cyanosis? That in the upper extremities, you will not see cyanosis, because it is after, if you look here, pattern ductus arteriosus, it is after that you have already given off the branches which supply to the upper limb. It is the lower limb which is affected, and in the lower limb extremities you will see cyanosis, which is called differential cyanosis, and you will see that in other diseases. I'll talk about that. I'll mention that specifically. PDA is normal in utero, but it is normally would close after birth. Okay, now the last thing here, we have the Eisenmenger syndrome. What is Eisenmenger syndrome? Eisenmenger syndrome is the uncorrected left to right shunt, either the VSD, so let's just draw it here, uncorrected ASD, uncorrected VSD, or uncorrected, let's say I'm just going to do it here, PDA. If you have any uncorrected left to right shunt, what's going to happen is there's going to be increase in pulmonary blood flow. So let's take a look. You have pushed the fluid into the right atrium. You have pushed the fluid into the right ventricle. In any case, you have increased the pulmonary blood flow, or the pulmonary artery, in which it goes into the pulmonary veins. You will have increase in blood flow, right? So when you increase the blood flow, the pulmonary arterial hypertension will develop. So it will lead to pulmonary hypertension. And when pulmonary hypertension, let's just do it like this. So this is known as pulmonary hypertension. When pulmonary hypertension develops, now the shunt will become right to left, because it's going to be harder for the right ventricle to push the blood back into the pulmonary circulation, because there's already a hypertension there. So what we'll do is it will just reverse that shunt, and it will the fluid that comes here, the blood that comes here, it's just going to go back, is going to reverse from right to left shunt. So it's going to go into the left side, which is left ventricle. That will cause increase in left ventricular pressure. See the illustration, and this is the illustration, or you can see it here if you want. Causes late cyanosis, clubbing, polycythemia. Okay, late cyanosis, all of them are causing late cyanosis. Late cyanosis meaning later in life you can have cyanosis. Clubbing is there, and there are other factors that can cause clubbing. Polycythemia, because now you have a low blood flow, right? You're causing ischemia, and this low blood flow, when it goes to the kidney and the PCT, they sense this low O2 or low oxygen levels. What they would do is they would release EPO, erythropoietin, which will cause increase in hematocrit, which is known as polycythemia. Age of onset varies depending upon size and severity of initial left to right shunt. All they're saying is we don't know when Eisenmenger syndrome is going to happen, but it will eventually happen when you develop pulmonary hypertension. So when you develop pulmonary hypertension, you will for sure develop Eisenmenger syndrome, but we don't know when would you develop pulmonary hypertension, because it depends upon how much shunt do you already have, how much fluid is going in the first place, right? And this is all about Eisenmenger syndrome. So let's just recall the whole thing and call it a day. What do we have? Simple things. Simple. We all are left to right shunts, meaning you will have acyanotic at presentation, but you will for sure have cyanosis years later. VSD most common, then ASD, and then PDA. VSD, which is, if it is smaller, it might self-resolve. Larger, it might be a problem, but it will not give you a murmur. What is a specific murmur? Harsh holosystolic / pansystolic murmur, blowing murmur at left lower sternal border. Okay, high yield, you will increase O2 saturation, will be seen in right ventricle and the pulmonary arteries. In ASD, you will see O2 saturation increase in right atrium, right ventricle, and pulmonary arteries. ASD, okay, going back, VSD is associated with fetal alcohol syndrome, while ASD is associated with Down syndrome. ASD, you can go into paradoxical emboli. ASD, the primary problem primarily it is due to ostium secundum problem. Patent ductus arteriosus (PDA), it is going to be normal in neonates, not in neonates but in fetus. But in neonates is an abnormal because it's supposed to close. Who's keeping it open? The PGE, prostaglandins, and low O2 tension keeps it open. Okay, it causes differential cyanosis. What are differential cyanosis? That in upper extremities it's all normal, when lower extremities are going to be cyanotic. It's called differential cyanosis. It is what is association? What is this guy associated with? Congenital rubella syndrome and preterm infants. I think I haven't mentioned that, but here, congenital rubella syndrome and your preterm infants. Okay, and you will have a murmur which is called machine-like continuous murmur. We didn't talk about ASD murmur. How the ASD murmur is going to look like? Well, the ASD, where I yielded the wide splitting of ASD, and also the murmur. The murmur for the ASD is going to be early peaking systolic ejection murmur. So early peaking systolic ejection murmur. It will be, again, best heard at the left upper sternal border. And we did talk about PDA, machine-like murmur, continuous machine-like murmur, and and it is associated with congenital and preterm infants. Eisenmenger syndrome. Eiser-Menger syndrome, we are talking about a reversal of the shunt, reversal of the shunt. When will it reverse? When you develop hypertension. Pulmonary hypertension will develop it. When will pulmonary hypertension develop? We don't know. It depends upon how much the shunt is. Okay, and that will just reverse the whole shunt, and it will be called as Eiser-Menger syndrome, and that is all.